Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, my name is Mejar Hafizul Asrar bin Abdul Razak. I'm an emergency physician from 96 Hospital Angkatan Tentera, Pangkalan LDM Lumut. Alright, so today I will like to share with you all regarding the shock topic, one of the topics which is very important from the ATLS. Okay, so definite outline. Okay. First, we will define shock. We describe likely causes of shock and trauma. We describe signs of shock and relate them to the degree of blood loss. Explain the importance of identifying the source of hemorrhage. Describe the proper initial management of shock in trauma patients. Describe the rationale of ongoing evaluation of fluid resuscitation, organ perfusion, and tissue oxygenation. And lastly, we will explain regarding the role of blood mutation. Definition of shock is a clinical syndrome which occurs when there is an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. Okay. Shock pathophysiology. Basically, it's regarding our cardiac output. Cardiac output is affected by two things, which is first one is heart rate, second one is stroke volume. And few factors that affects our stroke volume is number one, preload. Number two is myocardial contractility. This is correlates with the Murphy's law, and also the afterload. Okay. So as you know, if patient is having shock, the afterload will reduce cause vasoconstriction, and sometimes because of this, you'll have cardiac first, and your BP will drop later. Okay, so types of shock: hypovolemic shock, cardiogenic shock, neurogenic shock, septic shock, and anaphylactic shock. You can have a few types of shock when the patient comes in a single situation, but the most common cause or most common type of shock that you will see in a trauma patient is a hypovolemic shock. Right? Hypovolemic shock is the most common. It's regarding hemorrhage, which is defined as an acute loss of circulating blood volume. And as we know, the blood volume of adult is roughly around 10% of the body weight. So if you are 100 kilograms, the body weight, if you are 100 kilograms, 10% means that you will have around 7 liters of blood. And if you are a pediatric patient, this is especially for a body weight of less than 40 kilograms, roughly you have 80 mils per kilo of blood. Okay, so some pathophysiology of shock. Okay, shock, hemorrhagic shock will cause reduction in is due to reduction in blood volume, which will increase the sympathetic effect released of the catecholamine, which is mainly adrenaline and noradrenaline. It will cause reduction in venous return as well, and this reduction will cause arterial hypertension, which will further reduce tissue perfusion. And for the sympathetic effect, it will increase the cardiac contractility, it will cause tachycardia and peripheral vasoconstriction as well. And end up, it will cause anaerobic metabolism, which will cause acidosis. And this condition will cause myocardial failure, and lastly, multi-organ failure. Okay. Note by the side, any injured patient who is cool or cold to touch and is tachycardic should be considered to be in shock until proven otherwise. So for the initial assessment of patients coming to your emergency department with trauma, first we need to recognize whether it is shock or not. Usually shock is the first classic signs or symptoms is tachycardia, all right? And it can be affected by a few conditions I will explain to you later. And the second one is need to assess the blood loss, okay, whether it's anatomical and physiological. And this, as you can see, the sign and symptoms of hemorrhage by class. So basically, shock is you have 3 classes of shock, all right? And For the first class, usually you can relate it to blood donation. So if you donate a pack of blood, it will be roughly around 250 or 500 ml. Okay, so that is related to class 1 shock. And for class 2 shock, it can go up to 30% of the blood volume. For example, if your body weight is 50 kilograms, 30% means that it's already 1.5 liters. Okay, for class 3 shock, you start to have altered menstrual status and you have hypertension. You have tachycardia as well. Okay, you can go up to 40% of the blood loss. So if you are 50 kilograms, it can go up to 2 liters. Okay, and 2 liters can be due to pelvic fracture, and even femur fracture can cause a blood loss of up to 2 liters. Okay, and for class 4 shock, the severity is more than 40%. Okay, you have tachycardia, severe tachycardia, you have hypnea, your urine output reduced significantly, the DCS will be altered, and you will have acidosis. So for the estimated blood loss caused by fractures, the patient will come to you, patah tangan, patah kaki, patah macam-macam, right? So this is the estimated blood loss for the fracture. For pelvic fracture, it can go up to 4 liters of blood. For femur fracture, it can go up to 2.5 liters of blood. If you are 50 kilograms of weight, right, 2.5 is 50% of your total body weight, so it's a lot. Okay? A tibia can go up to 1.5 liters and femurs can go up to 1.5 liters as well. And for open fracture, bear in mind, okay, the loss is 2 or 3 times higher, okay, the risk. So kalau open fracture, lagi banyak blood loss. Factors that alter the vascular dynamics. Banyak factors. Okay. So the most common factors you can see first is patient's age. Young age, they are more resilient to shock. They will have tachycardia, tachycardia. And then for elderly, their symptomatic effect or reflex is reduced or less efficient. So sometimes their heart rate will not be as tachycardic as we are expecting. And then you can see for the severity of the injury as well, it will affect the vascular dynamics. The type and anatomical side of injury will also affect the vascular dynamics. If you see pelvic fracture or femur fracture, okay, of course, the blood loss will be high. And sometimes if a patient comes with a laceration or a big laceration over the scalp, okay, our scalp, our head is highly vascularized, all right? So if we don't stop the bleed properly, patient might bleed to death, okay, because a lot of blood vessels is over there. And time lapse between injury and treatment is also one of the factors affecting vascular dynamics. Patient late come to the hospital, or when you late give the treatment to the patient, okay, blood loss will be more because it's not stopped yet. And same, the resuscitation procedures that has been carried out will also affect the vascular dynamics. So if you don't give enough fluids, you don't give oxygen, and you don't compress the source of hemorrhage, you don't repair it surgically as soon as possible, all these things will affect the vascular dynamics and will affect the morbidity of the patient. Management of hemorrhagic shock, okay, basically is we have 5. First is physical examination, vascular access, initial fluid therapy, evaluation and monitoring, and lastly, definitive treatment. All right, physical examination, what should we do? First, assess the airway. As usual, airways must be patent, administer oxygen, but do not forget the cervical stabilization as well. And then you can check for breathing. Okay. While assessing the breathing, you can also check for tension pneumothorax as well, because it's clinical diagnosis. You can detect it early, and you can relieve it very fast. Okay? So you really need to be vigilant in assessing the patient by doing physical examination. Okay, circulation, control obvious hemorrhage by direct pressure over the bleeding site. Okay? We need to obtain adequate intravenous access as well. And our practice is to stop the bleeding. Remember, not to calculate the blood volume of fluid loss. Kalau ada tengah bleeding, stop dulu bleeding. Jangan fikir nak calculate berapa banyak liter, Kita stop the bleeding. Number 4 is disability, where we need to assess neurological examination to assess cerebral perfusion. So this might be a bit tricky because class 3 or class 4 shock, it will alter your mental status as well. Okay? However, by proper examination and assessment, you can actually differentiate whether this is a sensorium or GCS is due to TBI or due to the hemorrhagic shock by itself. Okay? And lastly, exposure. When exposing a patient, it is essential to prevent from hypothermia. This is very important because hypothermia it will affect the coagulopathy factors and it will worsen the SOT of the patient. Vascular access, the book says minimum is size 18 gauge, which is the green color, 2 large bore, 1 more antecubital vein. Okay, bagi yang warna pink or yellow or blue. Okay, because the fluid will not be sufficient. In pediatric population or even in adult, kalau tak dapat juga, or if you think that it's difficult for us to get any line, okay, you can always put IO, intraosseous. So initial fluid therapy, first choice, if you don't have bloods yet, you can start by giving ballast solution, Fixolite, Ringus, or Hartmann solution. You can give normal saline as well. And remember, the formula is 3 ml of Fixolite will replace 1 ml of blood loss, whereas for colloid is 1-to-1. So it means that 1 ml of colloid will replace 1 ml of blood loss. Okay. And colloid, right? As I mentioned just now, okay, types of colloid, you have gelatins, you have starch. Blood products are also considered as colloids. It can replace 1 ml of colloid for every 1 ml of blood loss. And the goal of resuscitation is to restore organ perfusion and tissue oxygenation, which is accomplished with administering preferred solution and blood product to replace lost intravascular volume. Evaluation and monitoring. Okay, first, what do we need to see? What do we need to check? Okay, check for the general condition of the patient. We check whether there's any return of normal PR or BP. Excuse me. All right. So for the evaluation and monitoring, first you look patient in general, okay, whether there's any return of normal pulse rate or normal BP, or whether the pulse pressure is normalized because the patient with shock, class 3 or class 4 shock. You will have narrowing pulse pressure. You can check for the improvement in central nervous system status. If the resuscitation is properly done, okay, and patient's ulcer sensorium is mainly due to shock itself, okay, patient sensorium, the conscious level will become normal, DCS will improve, okay? And you can see the general improvement in skin circulation as well. Okay, from CRT less than 2 seconds or 2 seconds, it can be normalized. Okay, and then you can assess the urinary output. We need to achieve a urine output of 0.5 ml per kilo in adult. For pediatric, it's 1 ml per kilo. For pediatric less than 1 2 ml per kilo. However, for adult, this depends. Okay, for example, if patient is coming already a known case of ESRF, okay, of course, you cannot use this formula and you need to properly assess the patient with other means of examination and inputs. And volume, note down there, the volume of urinary output is a reasonably sensitive indicator of urine perfusion. So normal urine volumes generally imply adequate urine blood flow, which equals to normal, adequate blood volume. And acid-base balance, metabolic acidosis is due to prolonged shock and inadequate resuscitation. Persistent acidosis should not be treated with increased fluid and not IV sodium backup unless the pH is 7.2, less than 7.2. So sodium backup is not a definite treatment or management for shock. Patients having left acidosis. Remember, lactic acidosis is due to the anaerobic metabolism in patient with shock due to the hypoperfusion. So if the pH of the patient is less than 7.2, you can give sodium bicarb, and it is only as a temporizing effect. Temporizing management is not a definitive management. Okay. So for the definitive treatment, we'll have fluid resuscitation, which does not replace early definitive intervention and surgery to control the hemorrhage. Remember, fluid resuscitation is not the definitive management or treatment. It must be the definitive treatment too is the DCR lah, basically, right? Surgery, blood loss, blood loss, etc. And the definitive care should be instituted within the golden hour. Okay. So responses to initial fluid resuscitation. What does this mean? So dia ada bagi tiga. Okay, divided into 3 phases. Okay, whether there is a rapid response, transient response, or minimal no response. Okay, so rapid response ni usually is due to a minimal blood loss. So blood loss to sikit saja, then we correct, patient will have a rapid response. Transient response ni usually due to a shock of type class 2 or class 3 shock, where there's a moderate and ongoing blood loss, and the response is a bit late. We can use specific blood to replace for this type of class of shock. And the book says that the need for operation intervention is usually likely means that there must be a source of hemorrhage that need to be surgically corrected. And minimal or no response, usually this is where the massive transfusion need. Okay. Resuscitation fluids, or what do we have? We have blood, we have lactate ringers, we have normal saline, we have colloids, hypertonic saline, and blood substitutes. The decision to initiate blood transfusion is based on the patient's response. Okay. Transient responders, non-responders require back cell, okay, red blood cell, and plasma platelets as an early part of the resuscitation. So kalau yang late responders ni, they need blood basically. And there is a scoring system that can be used. One of the scoring system is an ABC score. This ABC score can be used to calculate or to decide whether a patient needs an MTP or not. Okay, so massive transfusion or MTP lah basically, protocol. Okay. MTP or massive transfusion is defined as more than 10 units of cell within the first 24 hours of admission, and more than 4 units in 1 hour. And early administration of packed cell, plasma, and platelets in a balanced ratio is called this approach is called a balanced approach, or DCR, damage control resuscitation. And what are the endpoints of resuscitation that we need to achieve? Okay. So basically, these are all the targets: restoration of normal vital signs, adequate urine output, okay, urine output according to the age, okay, 0.5 to 1 cc per kilo per hour. You have adequate tissue oxygenation measurement, SpO2 okay, the lactate is improving, adequate cardiac index, stroke volume is good, cardiac output is good, BP okay, normalization of oxygen delivery, and normal serum lactate levels. Special considerations. Okay. Special considerations in diagnosis and treatment of shock include differences in the response to shock in extreme ages. So if you are an elderly, your sensitivity to of the baroreceptors at the carotid artery and also the aorta is reduced. Okay. So it might affect your heart rate. If you're an athlete, you're usually sometimes the baseline heart rate is less reduced, less compared to a normal sedentary lifestyle. Okay. If you are pregnant, of course, your blood volume can go up to exceed or be additional 30% of blood. So this will also affect your heart rate as well. Okay. Sometimes your heart rate, you relate to have tachycardia because your blood volume is still a lot. Okay. And hypothermia, it will affect shock as well in view of due to the coagulopathy, and presence of some medication and pacemakers will affect tachycardia or the treatment diagnosis and treatment of heart as well, especially beta blockers. Okay, and note down there, avoid the pitfall of equating blood pressure with cardiac output. As we know, because one of the components in stroke volume is cardiac output is peripheral vascular resistance, and the afterload. So this afterload and PVR, peripheral vascular resistance, is affected by the catecholamine, and catecholamine is released due to shock itself. So catecholamine, when it is released, it will cause vasoconstriction. So when you have reduced blood volume, you will only have tachycardia first, and the BP will still be normal, okay, due to compensation. So do not check the BP first. Always see the heart rate first. With that, I thank you.